Right next, we have a rapid-fire presentation talking about the analysis of concomitant and isolated venous injury in military lower extremity trauma by Dr. Anne O'Shea at the Brooke Army Medical Center.
Hi, my name is Annie O'Shea. I'm a resident from Brooke Army Medical Center. Thank you for this opportunity to present. I have no disclosures to report. So extremity vascular injuries are prevalent in military trauma. They account for approximately 12% of all military trauma in Operation Enduring Freedom and Operation Iraqi Freedom. However, knowledge gaps exist regarding the significance and optimal management of these venous injuries. With this analysis, we attempted to examine the impact of concomitant venous injuries on outcomes of limbs with femoral popliteal arterial injuries, and determine the implications of surgical management strategy, repair versus ligation of femoral popliteal venous injuries. We completed a retrospective cohort study using de-identified data from the Fasciotomy and Vascular Injury Outcomes database. The database contains information from limb casualties between 2004 and 2012 sustained during Operation Enduring Freedom or Operation Iraqi Freedom, and who underwent at least one limb salvage procedure. We identified 330 limbs with femoral popliteal vascular injuries and subdivided them in between isolated arterial injuries, concomitant arterial venous injuries, and isolated venous injuries. From those sustaining any venous injuries, we then further subdivided those between those undergoing venous repair and those undergoing venous ligation. We first examined isolated arterial injuries versus concomitant arterial venous injuries to determine the impact of concomitant venous injury on outcomes. Combined arterial venous injuries was associated with increased injury severity as determined by a higher extremity AAS score, higher proportions of limbs with mangled extremity severity scores greater than 7, and higher proportions of limbs with multi-level vascular injuries. Though incidentally, we demonstrated a higher proportion of tibial artery injuries in patients sustaining isolated arterial injuries on the order of 13 versus 4%. When examining interventions performed, there were no statistically significant differences in tourniquet use, shunt use, or final arterial repair in patients with isolated arterial injuries versus those with combined injuries. Concomitant arterial venous injuries was associated with increased rates of fasciotomies, 83 versus 69%, which is unsurprising given the current teaching on fasciotomy performance in traumatic venous injury. Concomitant injuries were also associated with higher rates of adjunct use as well, including TXA or factor 7. Despite differences in severity and the use of fasciotomies and adjuncts, we identified no difference in outcomes between limbs with isolated arterial injuries and those with combined arteriovenous injuries, though there does exist a trend towards increased amputation rates, infection rates, and DVT rates in combined arteriovenous injuries. These did not reach statistical significance. We then examined treatment strategies for patients with any venous injury, combined or in isolation, to determine possible effects on outcomes. Limbs undergoing venous repair were associated with patients with higher overall injury severity scores, 17 versus 14 for median. Otherwise, there were no differences in injury severity or associated injuries between treatment groups. In limbs with concomitant arterial injuries, there was no difference in type of arterial repair performed between venous injury treatment groups. However, in limbs with combined injuries, when examining frequencies of arterial repair versus ligation, those undergoing venous repair were associated with higher proportions of arterial repair, and vice versa, those undergoing venous ligation were associated with higher rates of arterial or ligation. Veins undergoing repair were associated with higher rates of vein shunt use. Otherwise, there were no difference in interventions performed in those groups. Interestingly, despite differences in injury patterns, severity, and interventions, we identified no difference between limbs undergoing venous repair and those undergoing ligation in terms of their outcomes. And then just a quick word on isolated venous injuries. Approximately 44% of these patients underwent repair. And in limbs with isolated venous injuries, rates of complications were still high on the order of 74%. And there was a significant amputation rate at 13%, speaking to the severity of these injuries. In conclusion, despite greater limb injury severity, concomitant venous injury was not associated with increased rates of limb loss or morbidity. Isolated venous injuries were associated with meaningful rates of limb loss and morbidity, and management strategies, repair versus ligation of venous injuries, did not influence outcomes or the fate of arterial reconstructions. I'd like to thank Dr. Kovar, my PI, as well as Dr. Christina Lee and Matt Burgess. Thank you.
Thank you. Good job. I find it pretty interesting that even though your combined injuries trend towards having worse outcomes is not statistically significant, because I think that's kind of one of what we have predisposed to think. And you mentioned that those that have significant isolated venous injuries have a higher complication rate, correct?
Correct.
Do you know if these patients were the patients that had ligation of the vein, or those? Do you have a comparison, I guess, of those that had ligation versus repair? Ones did worse than others for those isolated ones?
For the isolated ones, we haven't looked specifically at the repair versus ligation for those ones, but honestly, like we're under the impression that limbs with isolated venous injuries, the reason that they have such high complication rates is tissue loss and concomitant injuries such as orthopedic and nerve injuries as well.
Okay, Fox from Baltimore. To help you really prepare a meaningful abstract, what do you think that your message will be that will impact the management of people who work in a trauma center?
I think, determining your strategy and your repair versus ligation strategy of these venous injuries based on the amount of damage, and not, knowing that, whether or not you repair versus ligate these venous injuries is not necessarily going to impact the outcome of the limb.
So I think you have to be a little bit careful. You have to tease out that you're talking about a military population, right? This is
Yes,
not
sir.
a civilian trauma center. And also, the degree of venous injury. If there's a lot of venous injury, like from a blast injury, I think those patients are sicker. They lose a lot more blood than just sticking a clamp on a civilian injury into an artery. And then if you ligate the vein and you repair the artery, you do get limb swelling. So I don't really understand how you cannot have a little bit more morbidity, because it takes a long time to get those fasciotomies closed when there's a lot of swelling. And I think the ligation of the vein does translate into more swelling. So you might want to mention how long you followed those individuals and what their functional status was, and some things like that that will convince your reviewers that there really isn't a difference.
Yes, sir. Thank you.
Dr. Quiroga.
Hi, Elena Quiroga from Seattle. Great presentation, and actually confirms some of the early findings of the pop vein study that combined injuries, even that I still consider that worse, they are no worse than isolated injury. One of the issues of discussion is, what do you do when you repair or you ligate a vein regarding anticoagulation? Do you put this patient in heparin? Do you treat them? How do you keep that vein open? And when you mention DVT, are you talking about the thrombosis below the level of ligation that's expectable versus extending the thrombus and the risk of PE?
As far as management of them with anticoagulation or antiplatelet, unfortunately in this database we did not track whether or not they got antiplatelet or anticoagulation, so I can't really speak to that with this particular population. And then as far as, I'm sorry, what was your second portion of that?
When you mention DVT, are
Okay.
you talking about the thrombus that forms below the level of the ligation that's expected, or propagation above?
This was any DVT, not necessarily above or below the area of injury.
Thank you.
Just to add to that, when we looked at this in the POP Save It group, which a lot of people here contributed to, in the civilian setting, we found the same thing, that there was no difference in outcomes based on vein ligation or not, and concomitant vein injury. Did worse only because of the combined other injuries. But what's really interesting you have the opportunity to look at here, and I'm still curious about, is what about patients who have some kind of combined popliteal vein and saphenous vein injury? And is that different? I mean, do they have worse outcomes? If you have the opportunity to look at that, I'd really like to know that.
Unfortunately, I don't think we looked at specifically saphenous vein. I'll have to go back and look at the database, but I'm pretty sure we did not track on combined saphenous vein injury.
All right. Thank you much.
Thank you.